I think that in terms of just the phrase scoop and run, that needs to go away personally, because that means that you are as soon as possible running back to your ambulance. In my eyes, all I see is poor quality CPR, minimal airway management, no high quality, medicine occurring. And that's probably not going to give you the best outcomes.
We're discussing pediatric cardiac arrest management. So it's a very important topic, and we'll start off to saying, obviously, this is sensitive in nature, which we can appreciate, and we give a trigger warning for that. But overall, the main objectives of this are just to review cardiac arrest management, the pathophysiology, maybe the epidemiology behind it, and discuss best practice guidelines and the evidence for procedures and not for procedures. Do you have anything to add?
No, yeah, I think this is like some of the most stressful and difficult cases that we deal with as paramedics. But as we'll go through the evidence and the guidelines today, there's a couple of very specific things that we can do and really improve the outcomes for these patients. So I'm looking forward to going over that with you.
Absolutely. That's key, right? What we do truly matters, and it can potentially impact patients greatly by what we do. So that's the key takeaway. Even though they're hard, it's very difficult and understandably, let's talk about the optimal treatment plans. All right. First question. What are the key differences in assessing pediatric cardiac arrest compared to adult?
With pediatric cardiac arrest, statistically, like epidemiologically, the causes are kind of the opposite of what we see in the typical adult population. So most adult patients that present with sudden onset cardiac arrest is from a primary cardiac cause. So, MI, PE, those cardiovascular diseases, whereas pediatrics usually present with respiratory failure or decompensated shock from other causes. So, primary kind of respiratory infection that leads to hypoxia, and then we see the hemodynamic collapse from there, or things like sepsis and trauma and things like that. And we know that pediatrics will kind of compensate pretty well and look not that sick for quite a long time and then just fall off a cliff. And that's what usually we get called for. That's just kind of understanding that those are the primary underlying causes that we're looking at instead.
Which is crazy to think about, eh? Because what is it? Out of 350,000 adult cardiac arrests in North America every year, 100,000 of them being shockable rhythms. And primarily, if you're in a shockable rhythm, especially over 40 years old, it's probably something to do with cardiovascular disease, like an MI, etc. But the vast majority die from respiratory causes, and they're presenting rhythms most likely not a shockable rhythm.
hmm
How come?
Well, I mean, a lot of the cardiovascular disease that we're seeing in the adult population is just things that it takes a while for you to develop, and not a lot of children are going to have that. Not a lot of children are going to have coronary artery disease or atherosclerotic disease, right? Or a lot of risk factors for PE or things like that. But, kids can get injured and kids can get pretty sick, especially with respiratory diseases and things like that or infections. So that's more what targets that population, I guess.
Absolutely. So you said it, like, what if they die from asthma? What if they die from an infection, pneumonia, RSV infection leading to pneumonia, respiratory failure, drownings, foreign body airway obstructions? All these can lead to a respiratory death, which subsequently leads to hypoxia, acidosis, and eventually respiratory failure if not corrected. But how would that lead to a PA or asystole? Because that's normally what they manifest. They bratty down and go into PA and asystole. Why does that
hmm
happen?
With like hypoxic causes, the like final common pathway for that is that you're not going to be able to affect kind of the cellular respiration that's needed for like ion movements in the cells in your heart. So you're not going to be able to depolarize the myocardium as effectively. Your pacemaker cells are not going to be working as effectively in that hypoxic kind of environment. That's where you're going to see potentially the electrical activity continue to go on or even degrade into asystole, but usually at a slow rates. These bratty kind of arrests into asystole is kind of what we're seeing.
Especially like for the younger pediatrics, like they don't have a fully developed nervous system in comparison to an adult. So
hmm
especially when they're younger, they have a normal developed parasympathetic nervous system, but not truly a full developed sympathetic nervous system. And obviously, like hypoxia can cause vagal stimulation. And you talked about the effect it has on the action potential. Calcium needs to bind to troponin C to create that muscle contraction. And you need sufficient amount of oxygen to do that. So if you are experiencing asthma exacerbated drowning, foreign body airway obstruction, that leads to hypoxia and overall calcium confined to that troponin C, and that can lead to a PA arrest. So anything that has electric activity but no mechanical output, and overall that can lead to vagal stimulation. They have this overdrive of parasympathetic nervous system, so bradding down, and eventually go into PA and asystole. So that's a very kind of cursory overview, but that's typically the sequence of events in pediatric populations, obviously with more nuance and detail and some exceptions, but that's overall what typically happens. And if we tie back in, does that change how we actually assess these pediatrics in cardiac arrest? Do they typically die from respiratory causes?
Yeah, I mean, it's definitely something where you'd want to, focus your history around any kind of disease process or event that could have led to kind of respiratory failure, respiratory arrest, or any sort of disease like that. And then also your interventions are going to be like more aggressively targeting very high quality airway management and ventilation while you're doing your CPR as like your primary kind of start to your foundational resuscitation, I guess.
Do you think paramedics, physicians, and other healthcare providers, are we good at assessing pediatric pulse points, like a brachial or carotid or radial in some circumstances? Are we good at that?
No, I don't know the exact stats, but I'm pretty sure we are quite ineffective at that and probably, miss decompensation in these pediatrics quite often.
Mhm. And that's exactly why they say in the AHA guidelines and EOCOR recommendations, if you don't feel one after 10 seconds, probably don't have one or it's so low, it's causing inadequate perfusion, just start resuscitation efforts. Especially if they're younger and their heart rate should be quite quicker because they have a higher metabolic rate. It's okay. That's suboptimal. We need to do something.
Mhm.
So the key takeaways there is that they normally die from respiratory issues and management should primarily focus on airway and breathing because if that's the cause of the arrest, then that's what we should focus on, right? So at what point do we do 15 to 2 then for CPR in pediatrics?
So the typical like BLS response to that in terms of basic life support by the AHA is if you have two rescuers, then you do 15 to 2 so that you're able to continue high quality chest compressions while kind of maximizing that oxygenation and ventilation. But if you're a single rescuer, you continue going with 30 to 2 instead so that you can maximize those high quality chest compressions. That's my understanding at the point.
That's absolutely correct. Yeah, because if the main cause of death is probably respiratory and they have 2 to 3 times more likely of needing oxygen requirements, like we're going to maximize that by with 2 rescuers to give them that oxygen at 15 compressions instead of 30 if we have the personnel to do it. So to kind of bridge into this then, how would you assess and manage a pediatric cardiac arrest airway? Like, because we have different maneuvers we can utilize. Like, how would you treat this patient?
So it kind of follows the typical airway escalation strategy that we all advocate for at most base hospitals and stuff, where you start with the basics. So we want to make sure that we have really good positioning, right? Especially with kids that have larger heads. We need to put like padding under the shoulders to make sure that the axes are all aligned. And then using a two-person seal for your BVM, getting your adjuncts in, things like that can really help manage, especially that larger tongue that can get in the way of our ventilations. And then kind of just escalating your airway management that way, I think is reasonable, moving on to SGA if that fails, maybe moving on to intubation or things like that. Progressive approach starting with the basics as always.
What does the evidence suggest that for head positioning pediatrics, are they typically hyperextended too much, which isn't optimal for their management, or are they hyperflex, so their chin's touching their chest?
Yeah. I mean, if you look at the, average pediatric patient, especially as they get smaller, if you put them like supine, their head's going to tilt forward because their head's much bigger in comparison to their body. Then they're going to end up obstructing their airway that way. However, you can see overzealous providers sometimes, exaggerating that head tilt chin lift. And then that can also actually cause kinking in the trachea because the connective tissue in there is a lot less developed. And the trachea can narrow down because you're pulling on it and positioning it too much like that. So kind of a good neutral position that we always talk about, like that parallel plane is very important.
And you mentioned a good two-handed mask seal. So we've probably heard this adage so many times that the one skill that paramedics and other healthcare providers neglect is BBM ventilations. And do you think BBM ventilations theoretically should be difficult in a pediatric patient in comparison to adult, or they should be relatively easy with good technique.
Yeah, so it's going to be a lot more like delicate kind of maneuvers. Like with an adult, a lot of the time, what becomes most challenging is being able to fit your hand around like their face and the mask and creating that seal. Whereas with pediatrics, it's kind of finding that good angle that you're getting good chest rise and fall without insufflating the gastrium, and also creating that seal around obviously just smaller structures, which is why having both hands involved in that, grip, pushing the face into the mask, and then having a partner there to deliver the breaths is much more effective.
Remember the acronym like boots for difficult like
Yeah.
ventilations, like if an animal has a beard, do they have like obstructive process like sleep apnea, all these other factors? Like pediatrics probably wouldn't have those characteristics, obviously, right? Unless they have some maybe malformations in their facial structures. But typically with a good two-handed mask seal, optimal positioning with a pillow or blankets, like you should get that.
Mhm.
You said something key, like we deliver the ventilations carefully. So how can we actually assess that the BVM ventilations are sufficient in providing adequate amount of oxygenation in these patients?
Obviously, just going for that gentle chest rise and fall that they teach you in those basic courses is always really good. Everyone that's VSA should have end tidal CO2 in a continuous fashion. So you can look at your end tidal waveform, make sure you're not bagging them down into very low numbers with a good 4-point waveform and everything like that. If you have it, there's some devices out there that can kind of tell you what your tidal volume is as well. That's available on the Zoll. And that's really good for safety. Or having a manometer on your BVM is also a good option to making sure you're not increasing your airway pressures too much.
I saw in Zolls coming out with their new monitors and they have those devices and you can literally see how much ventilations you're giving, how much volume you're giving. So that's completely so useful. Because do you think like we tend to overventilate or underventilate, especially pediatrics?
Well, in all comers, we overventilate a lot, and then especially in pediatrics, absolutely.
Mhm. And that can lead to gastric insufflation, that can lead to increase into thoracic pressure, and subsequently decreases venous return. So
Mhm.
you can see how that compromises outcomes. The key is that get one breath and just see enough to rise the chest and have that good two-handed seal. But let's say you have an OPA in place and you're still not getting a good end tidal, they're not pinking up at all, and you're not getting that good mass seal. What do you think we should progress to at that point?
Yeah. So, from what most clinicians will prefer to do, and what the evidence supports, just in terms of first pass success rate, is a supraglottic airway that will typically get you the best success rates, much easier to do, quicker to do. I think most services are using like iGels for pediatrics or LMAs, and those are a really good viable option for SGAs for pediatrics.
What's the first pass success rate for an iGel?
So in the literature, I've been seeing between in the 80s and 90s for pediatric iGels, whereas endotracheal tubes, just as a comparison, is typically in the 40s for first pass success, just because of the skill is just so much more difficult, especially in the pediatric population.
Super black airways, especially the iGels, like what a superior airway device. You can put it in quickly. The key, I believe, the studies that it usually takes on average all of healthcare providers like a couple minutes to 5 minutes between the last ventilation till the next ventilation. So you may put it in quick, but people forget to ventilate just because of human factors and being busy. But once we
Mhm.
know that, it's okay, put it in first pass success rate and then start ventilating right away and secure it. The key takeaway is that we should not necessarily rush to intubation unless it's all dependent on the user, their experience, their comfortability, and the patient's like pathology and what's actually going on. Because if you said like first pass success rate for pediatric intubation is around 40% in
Mhm.
comparison to Nigel, which is in the 90s, it's what should we decide to do?
There is evidence out there, so they're comparing the first pass success between these two modalities. And then they also compare like mortality and things like what patients actually care about, which is, yeah, like I said, mortality and cerebral performance category or neurological outcome. And those are equivalent between the two groups. So, the procedure is easier, higher first pass success, and the outcomes that patients care about are the same.
So basically, we should decide carefully, but we should kind of navigate toward maybe the supraglottic iGel side just because lower complication, higher success rate, and about the same outcomes. It makes sense objectively to go down that route. Obviously, there's caveats in that statement because, again, it all depends on the circumstance and your experience, but That's interesting to know. That's what the literature says at this point in time. Do we have even pediatric bougies that could help optimize pediatric intubation?
Right. I don't know of a service that has those available. No.
So I believe the smallest tube that an adult bougie can fit over is a 6. Then you think about video laryngoscopes too. Would those help?
Yeah, I mean, so the McGrath, which is the most common laryngoscope used in the pre-hospital setting in our region, does have blade sizes all the way down to 1. So you would be able to use it in like some of your smallest patients with better airway visualization. Obviously, you still need to train really well with those devices to get better first pass success rates. So that's yet to be determined.
That'd be a good research study.
Yeah, I think so.
You randomize video laryngoscopes to an IGL group or supraglottic airway group.
Yeah, or even just see if you can improve it over direct laryngoscopy to see if we can, get over that roughly 40% there.
What's the complications of intubation?
So obviously, esophageal intubation, it does happen. It's rare, but it's a catastrophic complication that has, led to some really poor outcomes in the past. And then, the trauma during laryngoscopy is also something to be concerned about. Pneumothorax, right main stem intubation, things like that, are things that are a lot easier to do, especially in the pediatric population than the adult population. So further speaks to kind of the superiority of SGAs for our purposes, at least early on in the resus.
Mm-hmm. And if we think IGL is obviously not a benign procedure, but in comparison to intubation, it's relatively safe. The only true complications may be trauma and like blood staining. And the odd time you get this tongue folding. So putting it in and it keeps hitting the tongue is obviously can't be inserted, but if you just turn it 90 degrees and put it in, they kind of mitigate that. So overall, it's a pretty good cell to focus on basic life support techniques of good mask seal, get that ventilation over a minute. And if you need to move on to something better, an IGL seems like a very good option to do it.
Mm-hmm.
Circulation. What do you think? How would we treat this patient's lack of circulation?
So high quality CPR, just like we do for adults, you want to use that kind of, pit crew setup. So you have very minimal pauses during, shocks or rhythm analyses. You want to make sure you have a fresh rescuer providing very high quality compressions. That's going to be the foundation of our resus. If you don't have that, then you're not going to get a good outcome. And then we can talk about, epinephrine and other drugs, but that's the foundation.
What's the largest cardiac output CPR can generate in comparison to normal cardiac output? Do you remember the percentage?
I don't remember it verbatim, but isn't it like 30% or something like that?
Absolutely correct. It's literally like 30%.
Okay, perfect.
So the best CPR we can do generates about 30% of what the heart can do. Early and good CPR is what saved lives empirically. But then you mentioned epinephrine. Why is epinephrine beneficial?
What we were talking about earlier with like the respiratory causes that increase like that parasympathetic tone that cause the bradyarrhythmic arrest and like vasoplegia, all those issues. Epinephrine is going to help start and reverse kind of those processes. So we're going to have cardiac stimulation with the beta 1. So it'll increase our chronotropy, our dramotropy, inotropy. So bigger, faster, stronger contractions of the heart. And we're also going to have, systemic vascular resistance increases to kind of shorten that circuit and increase, hopefully, the perfusion pressure to the patient's brain, to their coronary arteries. And then that's hopefully how we're going to increase or improve outcomes with epinephrine, I believe.
Mm-hmm. And is epinephrine a potentially life-saving medication?
It does increase rates of ROSC, especially when given early in cardiac arrest. So my opinion would be yes right now for that. It still has its risks, especially in higher doses and or higher total doses. So I think we could talk about that for hours too. But overall, it is a good medication for us to be giving, especially early in cardiac arrest.
And you outlined all its mechanisms, and it is potentially life-saving medication. All the pre-hospital systematic reviews and meta-analyses at this point suggest it's more likely to bring patients back. It's more likely to get you to the hospital, more likely to maybe discharge you in some studies, but no real change in neurological outcome. That's pretty good characteristics, but you said the key thing is that it has to be given early. And I forget the authors of the study, but they tested this in adults and the pediatric population. And if you look at the pediatric portion of that study, every minute delay of epinephrine increased mortality by 9%. So it's like, that is significant. If we know that and we need access, what's optimal then? Should do an IB or should I do the IO?
Right. So I think this was done in adults. And unfortunately, I also can't remember the names of these authors, but IV epinephrine led to higher ROSC rates than IO epinephrine. So IV should be our first route, first line route. If we're able to get, if there's any delay to IV, it's very reasonable to move directly to IO. So right now, the recommendations from our base hospital is that you have a good look for an IV. If you see something that looks very easy to hit that you're confident you'll be able to get, go for it. If not, kind of go down to IO just to mitigate kind of those delays. Is that similar to your recommendations or?
Yeah, because that's part of like the PALS guidelines and the AHA guidance, core recommendations. Because like you said, the IV route is more bioavailable. And I remember looking at the studies in the adults. When you compare the IV to the IO route, IV is superior, but also depends on the IO site. Because if you look at the tibial site, which is primarily the site we use for pediatrics, that doesn't have a good absorption rate. However, in adults, if you use the humerus, it takes about 3 seconds to get medications engaged from the shoulder to the heart, which is better. But you also think about the first pass success rate for an IO versus an IV. Because what's the first pass success rate for an IV, especially in a pediatric population with poor perfusion? Do you think it's likely to be high?
No, personally, I think mine's probably close to 50%. It's just give or take. Whereas IO is very close to 100% if you size it appropriately. So
you get in this catch-22. It's, do I do the route that's more likely to be bioavailable and work? Or should I do the route that's more likely to be successful and can do it quickly? But you're right. It all depends on your guidelines and the recommendations and everything. But most kind of directives or protocols, depending on the area of the world you live in, look first. But if you don't see one, you can move on to an IO at that point. And this is interesting. The Handtevy method. Have you reviewed this with Dr. Handtevy in Florida? I believe he's based out of.
I haven't heard that before. So teach me.
They're like, we're having inferior outcomes with pediatric cardiac arrest. The traditional way to do this is just scoop and run, get them to the hospital. But we know that leads to poor CPR, poor therapies. And that's why it's recommended that we stay on scene for at least 20 minutes for even the pediatric populations, unless there are true exceptions. But if the Handtevy method, they just took away the choice. They standardized it. They're like, don't worry about the IV. It's hard. It's stressful. You're worried about it. Just do the IO. Then the IO success rate went up. The ROSC rate went up and better outcomes just by taking away that decision, just being like, just go straight to the IO. Don't even look. Let's get this in. Let's get the drugs administered as timely as possible. So like, that's pretty interesting. Like a cool kind of case report or case series.
Absolutely. I mean, yeah. If they have the data to support it, that sounds excellent. And we should, adapt our practice to that. Do you know if it was like a large study or was it just a case series? It's a case series.
Oh, I think it was a case series. Don't quote me on that. We'll have to review it once again. That'd be a good article to review. But yeah, they call it the Handtevy method. Basically, it is gave out a bunch of recommendations like stay on scene, focus on high quality interventions, make sure you're getting that mass seal, make sure you just kind of standardize and just do the IO and do drugs and calculate them appropriately, which kind of bridges into the next question, because this is nerve wracking. And we know that pediatric populations are at high risk for medication errors, and they're normally 10 to 100 times the dose that it should be. So how should we calculate this safely?
Right. So most governing bodies do allow their paramedics to use things like the Broslow tape or Pedistat, which is really helpful because you just, with the tape, you just measure the height of the child and then you follow the grid where they kind of land on. And it tells you the dose that you should be giving for your most common kind of PALS medications. Pedistat is also a great option because you can use it en route to a call. You get the patient's age over the air. You confirm it once you're on scene, obviously. And then you can do your math through that app and it gives you, validated drug doses.
I love that we're moving towards this because from a patient safety perspective and human factors perspective, the best way that's proven to mitigate errors and ensure safety is by just calculating the mils or looking at a chart that gives you that. such as the Broslow tape, right? Like
Yeah.
pediatricians with 10 years of pediatric experience and schooling alone use Broslow tapes. It's like, why are we using that? You
Yeah.
get rid of that cognitive load, the dosage right there, it's standardized. But can we use them as a substitute to the medical directives? Because some medication dosages are different. Can we use them as a substitute?
So my understanding is that you can use them as a substitute. And yeah, because they're based on the most up-to-date pediatric guidelines. I think you can substitute them in my region anyways.
Mhm. It's written in the preamble of the medical directives at this point in time, in
Hmm.
2020, but that could change depending on. And I know stat, it's all based hospital dependent, so it's all depending on the jurisdiction. But
Right.
like you think about a very functional app, like reduces that stress and just gives you the dosages and everything.
And it's obviously very stressful situations when you're trying to do these drug calculations for these pediatrics. You're on scene. There's a parent that's freaking out. There's a sick child, and you're trying to do this math on your notebook. The potential for error is just so high that I think, yeah, using an app like that is really useful. And then this is where your cross referencing with your partner is so important too. Just showing the app to your partner and saying, what would you give based on these findings? And then they, tell you without you prompting them. I think that's really important.
And that's best practices. There's no ego. Always just look at a standardized dose, or the medical directives do give you kind of like a dosing chart too. So use
Mhm.
any aid at your disposal. Because can you imagine working 3 night shifts in a row? It's the end of your set of shifts, 6 o'clock in the morning, you get a pediatric caregiver else. And like you said, people are screaming at you. It's a high stress call. Do you think we'll be functioning at maximum effort, or we're obviously going to be distracted? And that does matter for performance.
Absolutely. If you have the time, doing those calculations while you're en route is definitely a good idea. You can kind of develop your cheat sheet to reference throughout your call that you just look at it. It's okay. This is my gel size. This is my tube size. This is my epi dose. This is my midaz dose. I really like doing that. And a lot of my colleagues have started doing that as well. And we found it quite helpful and just takes a lot of your stress away once you're on scene. So,
And just talking about it with your partner and say,
exactly.
okay, this is the potential age of the patient. This is what we're calculating their weight on. Like, these are the drug dosages. This math makes sense. Let's look at the books together. That's so beneficial. I'm glad you're really going towards that. Then what's the preferred route then for cardiac epi for peds? IVIO or intubation?
So, yeah, it's always going to be IVIO. You know, giving drugs ETT is, I think, a last resort. And we just talked about how you're probably not going to have an endotracheal tube in these patients anyways, because you're going to be, progressing probably towards iGels or SGAs instead, right?
And you need like about 10 times the dose. So you get the
Yeah.
same absorption rate, but basically you're causing like a shunt and you're dumping all this fluid down them. So yeah,
Yes,
that's last ditch effort.
absolutely.
So can we do a humerus IO on the pediatric population then?
I don't know. I don't think so.
This all depends. Is the nuanced answer to it. All depends on your area, your jurisdiction, and base hospital. There is a potential risk of the growth plate in the humerus site. But yeah, tibial IOs, as long as they meet the minimum weight requirements, which is about 3 kilograms for the pink size needle, yeah, they can use that. But it'd be interesting to look at the orthopedic literature to see if there's any detriment in patients that survive cardiac arrest that received a humerus IO, if they had any impact on the growth.
Yeah, I think that's really important evidence for us to, better understand what to do with these patients because we saw that in the adult population, humerus IOs had higher ROSC rates compared to tibial IOs. So to understand kind of the risk benefit in pediatric population seems really useful.
So we kind of mentioned this then. So for scooping and running, should we do that anymore? When can we do that? Is it advisable? What do you think?
I think that in terms of just the phrase scoop and run, that needs to go away personally, because that means that you are as soon as possible running back to your ambulance. In my eyes, all I see is poor quality CPR, minimal airway management, no high quality, medicine occurring. And that's probably not going to give you the best outcomes. So I always say, we need to get a good, high quality foundational resus. Even if we're going to be transporting early, relatively early, we need to get those high quality markers done first.
And that's a habit that's hard to turn around because that was just the normal procedure we did for years, right? And obviously it's uncomfortable. We don't do as many pediatric cardiac arrests as in comparison to adults, which is a positive in the grand scheme of things. But we should stand seen and render those high quality interventions because you think, okay, what are we running towards the hospital for quickly? Because they can do CPR, they can do airway management, they can give drugs, and we can do all that depending on our resources. So that's what we should focus on. And that's why our medical directives at this point don't stipulate an age of when you stay on the scene versus when you go right away. The only time they do speak to that is the true reversible causes. What if it's a non-opiate related overdose? What if a pediatric patient takes some pills from their caregiver and now you have polypharm overdose? Do you think that would warrant prompt transport in conjunction with treatments?
Yeah, absolutely. So that's a case where, some very specific kind of pharmaceutical reversal agents are available in the hospital, but aren't for us. But you're still not doing that child any favors if you sacrifice good CPR and good airway management on your way to that hospital, right? Second of delay on a high quality CPR is going to affect those outcomes.
And same with trauma. Like this is for medical cardiac arrest. Like is trauma different in the pediatric population leading to cardiac arrest?
So we're still going to go for the reversible causes that we can address. But yes, absolutely. We want to bring those patients to, a trauma center and an OR. That's what saves trauma patients. But obviously, we're still going to want to do our good foundational resus and then reverse what we can.
What about drowning? Would that change anything?
I mean, so drowning is a hypoxic cause of arrest. So if we can provide really good high quality airway management, which we talked about, and oxygenate these patients, ventilate these patients, then I think that's the best thing we can do for their outcome.
Couldn't agree more. Obviously, the cause of the arrest, like you said, is hypoxia. If you can secure an airway and provide that sufficient amount of oxygenation and ventilation, yeah, you can stay on scene. But what if you can't secure an airway? Allow the paramedics to make choices. Okay, I can't secure this airway and address this reversible cause. Maybe we should get going. Just give them that choice and support, right? Because you can appreciate how difficult that circumstance would be.
Absolutely. Yeah.
And I know this question has come up. Like if you have a drowning and it looks like frothy sputum's coming up the tube, what do you think's being washed out?
So usually that's like your surfactant being washed out with the fluid that's been aspirated, right? So obviously you're going to have issues with de-recruitment and atelectasis with that. But, how are we going to treat that with high quality ventilations and airway management?
So should we still suction that?
I actually don't think you like have to when but I think I'd still be suctioning, but yeah,
that's the answer. So this question has come up a bunch and see how you hesitated until like you thought about it. Because the surfactant's washed out from the drowning and that can cause all those problems. But paramedics are worried if you suction out, it takes away that surfactant even more and exacerbates the process. But the answer from the medical physicians is, unfortunately, the ship has sailed at that point. Like the surfactant's gone and it's the water mixing with it obstructing the airway. So we should provide that good, optimal airway management, ventilation, suctioning if need be. And if they live, they can regenerate it. They can give you the surfactant in the hospital and everything too. So that's technically the answer.